So for this video, we're talking about muscular dystrophy. Here it says DMD, Duchenne muscular dystrophy, which is the most severe form. We'll also talk a little bit about Becker muscular dystrophy. They are monogenic disorders, and they can be caused, again, by a variety of mutations. There are different alleles. This is another large protein. It codes for dystrophin. The DMD gene codes for dystrophin. And what dystrophin does is it protects the integrity of muscle cells, particularly by keeping actin in its place. If you have insufficient dystrophin or you don't make any, if you have that nonsense mutation that doesn't allow you to make dystrophin, actin gets released with every muscle contraction, and it causes weakness of the skeletal muscles and the heart muscle. Remember, muscle is one of those tissues that does not divide and reproduce itself. And so the loss is irreversible and the disease is now progressive. Transmission is sex-linked recessive. On the X chromosome, it is passed from mother carriers to affected sons. Incidence is 1 in 3,300 to 3,500 live births, almost all males, occurs in all races and ethnicities, has a high spontaneous mutation rate, so you might not have a family history of muscular dystrophy and yet have an offspring with muscular dystrophy, unlike CF and sickle cell disease, which have been stable for many thousands of years. Okay, so here's our pattern. Remember that only women have 2 copies of the X chromosome, and there's some weird little things that are going to impact how this disorder looks, both for carriers and for people who are affected by the disease. So if we have 2 parents who have normal dystrophin, homozygous, mom has 2 X chromosomes that make lots of dystrophin and protect her muscle cells. Dad has 1 X chromosome, because that's all he gets, and that one makes normal dystrophin. The risk for inherited DMD is 0 out of 4%. Spontaneous mutation, we do not have a number for, but it does happen. We are aware that it does happen. It's thought to be rare, but not impossible. Now, if we have a woman who carries 1 X chromosome, hit my mouse pad there. She has 1 X chromosome for DMD and 1 normal chromosome that gives her dystrophin. And the father will be hemizygous because he only gets 1 X, and he's got normal dystrophin. The risk for passing Duchenne muscular dystrophy is 1 out of 4, and it will only affect males. It will be 1 out of 2 males, and the risk for passing the gene on to females, who will then be carriers, is also 1 out of 2. But the overall risk is 1 out of 4 because 50-50 chance you're male or female. And you can kind of look at that on the Punnett square. I wish they had made this a different color. But with a mom who's a carrier and dad who is normal, what you see is that mom passes on the affected X chromosome to half of her children. Okay? Now, if mom is a carrier and dad has Duchenne muscular dystrophy, which would be rare because most men do not live that long with Duchenne muscular dystrophy and certainly would not want to pass on, their gene if they can avoid it. The risk for having Duchenne muscular dystrophy would be 50%. All of the males are affected. Risk for carrier status, 1 out of 4, because 1 daughter out of 2 daughters will get it. So that gene is getting passed on 3 out of 4 times. Only 1 X chromosome is normal. Now, if mom has Duchenne muscular dystrophy and dad has Duchenne muscular dystrophy, I'm not even sure that that's a realistic situation. All the children will have Duchenne muscular dystrophy, but that is rare. Most people with Duchenne die in childhood or early adolescence. Okay, so we already kind of went through dystrophin maintains the integrity of skeletal and cardiac muscle. It surrounds the muscle fibers and secures actin and other protein strands. If we have these mutations, functional dystrophin formation doesn't happen, and the muscles become unstable and break down with every contraction. So it is not part of the state-mandated newborn screen because there is nothing you can do about it. Remember when we talked about this last week, the newborn screen screens for disorders that are rare, not easily seen as part of a routine exam, but treatable to prevent complications of the disease. Duchenne muscular dystrophy is not at the moment a treatable disorder. Usually what happens is we see symptoms in young boys, problems with muscle weakness, problems with walking, particularly upstairs, problems standing from a seated position, problems with toe walking, and they do a muscle biopsy, and that confirms the diagnosis because you will see degeneration in the muscle tissue. At that point, you may do DMD direct sequencing testing, especially on the female children in that family or females in that family for carrier status, and now it can be used for prenatal diagnosis similar to CF. Usually you see the muscle weakness in the neck or the hip girdle. In Duchenne's, it is seen very early, and Becker's a little bit later. Okay. 2 and 5 years is typical onset, usually about 3 years of age, especially with an active child. The muscles of breathing and the heart muscle are the ones that are most significantly affected. Skeletal muscle is the most obvious initially, but it's usually the breathing muscles. Life expectancy is significantly reduced. This is a disorder that people die from. If they don't die from pneumonia because they have reduced ventilation, which doesn't mobilize secretions as effectively. They can't cough as effectively. But yes, this is something that people die from. There is no cure. They can give steroids to slow the rate of muscle cell degeneration. Maintaining a normal weight and mild exercise will slow it as well, prolong mobility. And doing things that enhance cardiac and respiratory supportive care. You really have to be careful not to overtax the heart, because every time the heart is stressed and there's increased contractility, you're going to be losing cardiac muscle cells. And then we're going to go right into Becker muscular dystrophy. It is a similar disorder, but in this disorder, it's also inherited through the X-linked recessive pattern. There is still a mutation in the dystrophin gene, but some dystrophin is produced. It's not sufficient, but that means that you'll see symptoms later, so maybe in adolescence instead of at age 2 or age 3. And folks have a longer lifespan. They can live into their 30s, and sometimes they father children, men who have this disease. It is still degenerative. It is still progressive. It will still eventually result in death for people who have it. But individuals might not be diagnosed until after they pass those genes on, so genetic counseling might be required. Now, before I talk about hemophilia, I want to mention something about X inactivation and how that impacts carriers. So if you recall when we talked about the cell cycle and gametogenesis and a few other things, I mentioned the concept that in early fetal development in females, one X chromosome in each cell is inactivated at random. And that's to prevent an overdose of the genes on the X chromosome. With people who have an X-linked disorder, if the cells that inactivate the X chromosome that has normal dystrophin are skeletal muscle cells or cardiac cells, you can see some symptoms of muscular dystrophy in the female carrier. And you will very often see cardiac problems emerging earlier in life in women who carry the trait for Duchenne and Becker muscular dystrophy because they are producing less dystrophin in those cells. I just wanted to mention that because it may impact how you approach patients whose children have this disorder. You will also want to counsel the mother to have her heart checked frequently, to consult with a cardiologist, and to adopt a heart-healthy lifestyle, maintain moderate weight, maybe not stress her cardiac muscle too much. So that is it for muscular dystrophy. We'll talk next about hemophilia, another disease you should be familiar with.